Nice new music, too. And good afternoon, everyone, and welcome to PerfWeb 75, Day 4. I'm your host, Joe. Oh, what's going on? We're having a problem. We all got it? We're good? We're having, there we go. Is that better? Okay, welcome to PerfWeb 75, Day 4. I'm your host, Joe Basha. First time I've been in the newly tooled studio in 2022. Tomorrow, I'm kind of excited about tomorrow's program because we're going to be doing a simulation with a new Eigenflow ECMO simulator, ECMO circuit and pump, patient monitor, ventilator, you name it, transonic elsimeter, a whole bunch of different stuff. I'm really excited about it. We've done a lot to the studio that you're going to see over the next several weeks. More and more and more things. We can't throw it all out at once because it has taken us a while to figure out how all of this stuff works. But anyway, very quickly, our purpose here is to bring you the very best in perfusion education and really critical care medicine education. We are involved not only in the operating room, but also the intensive care unit. And we really want people to be included in these conversations. We would like for anybody watching today who has an interest if you look down at our scroll bar, you'll notice over time you'll see contact at perfusioneducation.com, our website. Reach out to us. Tell us you want to be a part of the faculty. You'd like to give a lecture. We would love to highlight you. It doesn't matter where you're from. You could be from anywhere in the world, and you can be a part of this program because we technologically have the capability of doing that and doing it well. So I'm really excited about a lot of things. Today's program, of course, I have to thank our next, the person who I'm going to introduce you to, John Ingram, who I'll introduce you in just a moment. Thank him for calling in on Tuesday, I believe it was, and helping Tammy out, or Monday, whichever day it was, and being a part of the Tammy Sparacino Journal Club. But we've got a lot of different things going on, a lot of different programs. Of course, thankfully, COVID is starting to wane and the numbers are coming down. Hopefully, we don't have any super spreader events from the Super Bowl and everything else. So we're hopeful that we are moving past the pandemic phase to an endemic phase, and that it's just something we're probably going to have to live with for a very long time. But we certainly aren't seeing the kinds of cases we were seeing in terms of volume, acuity, and everything else. So my own experience is things are getting much, much better, and I hope that is for you and your families as well. So without further ado, let me introduce our speaker for today, John Ingram, with his Knowledge Nuggets episode number 15, the first Knowledge Nuggets of 2022, and it is going to be on septic shock. John, great seeing you. How are you?
Hey, great. How's it going, Joe? Good to see you again. You can hear me okay, I guess? I got a new computer.
We can hear. You got a new computer?
Yeah, I got a new computer for today's episode anyway.
Outstanding. Well, we can see you. We can see you great. You look good. You look healthy. I hope things are going well for you out there.
Yeah, I'm back in Key West for a couple days, and we're coming live to you from Key West.
Very good.
And still coming down here and checking on the house once in a while, but still spending, almost all my time in Orlando working, and hopefully that transition of more down to maybe 1/3 time there and 2/3 time here, I'm going to start, I'm hoping in July maybe.
Well, fantastic. Well, I'll tell you, you picked a really good topic. Septic shock, so we'll just dive right into it, is a devastating diagnosis with an extremely high mortality associated with it, and being able to affect the mortality in septic shock patients by 10% is considered huge in that with that particular problem. So I'm very interested to hear your lecture on basically what it is. I'm hopeful that you're also going to talk a little bit about septic shock like syndromes, where it's the patient isn't actually septic, but they're acting as if they are, with all of the same, blood pressure problems and cardiac problems and fluid retention problems and all of those kinds of things. So I'm going to turn this over to you, let you do this lecture, and we can have some, I think, robust discussions about this after your lecture. So, John Ingram, first 2022 lecture, Knowledge Nuggets, episode number 15.
All right. Thank you for that, Joe. And excited to be a part of the new and upgraded and improved studio. I understand you've done some incredible upgrades there, the guys were telling me about prior to the show off camera. So what we have is today is episode 15, February 17th, I believe, 2022. I'm going to have to see how do I get that myself off of the, here we go. Okay, fixed it, I think. Okay, so as always, if you guys have never watched the Knowledge Nugget show before, as always, I have no disclosures on this or any other presentation that we've done so far. And our motto here at Knowledge Nuggets, and the reason we came up with the name, is you can spend a little time and expand your mind. We try to give you something you can really take home, take back to the OR with you, take into the clinical setting, and actually apply and use. Because sometimes, Joe, we go to a lot of these meetings and lectures, and you come away thinking, what can I really use from that meeting? And so this is why we tried to come up with this program, to try to hone in on things that hopefully people can actually use, so that hopefully it's a valuable time spent. And I think if you'll see on the next slide, you'll see that our format, we hope to find a noteworthy topic each time, something you can take home so that you can be a better clinician tomorrow. That's my aim, that's my hope. And one of the things I also did was added a little golden nugget in the upper right corner of the screen. And that's something that while you're looking at the lecture and you're watching it, if you say, hey, let me snapshot this, this is something I can tuck away. The information on this screen is valuable, and this is something I can take with me. So look for those little golden nuggets in the right upper corner of the screen. So normally, there's just a 12 to 15 minute high impact segment. Then we have something that's just completely unknown. It's a surprise. I picked something called the Gem of the Week, an interesting topic, a pertinent topic that we spend about 3 minutes on, and then we can conclude it with about a 15-minute discussion. But I will say that today's presentation, being septic shock, is probably going to be more like twice that long, something along those lines. This is a gigantic topic, Joe, as you mentioned, and I'm going to try to hone in on where the rubber meets the road on septic shock. What is really happening inside the body, and why do we see all these manifestations when we say that somebody is in septic shock? Any future questions, emails, comments on shows, suggestions for future topics, please email me at john.ingram@perfweb.us, and I will respond to everyone who sends me an email at that address. So please feel free. So let's start. So Joe, I changed the background just for this particular topic because you had actually said something a minute ago that is exactly why I use this storm-like gigantic wave of a background to talk about septic shock, because it is a tremendous storm that goes on inside the body, a tremendous wave of cascading events that brings us to what you said. It was exactly right. A very high mortality rate in the hospital is attributed to septic shock, and we're going to look at that briefly. So
yeah, it's like a tsunami.
Yeah, exactly. So I use this background just as a nice little mix it up for this topic. So let's start off a little bit from the beginning so we can bring everybody into the fold, no matter what your education level is on this. And just list what is the definition of just shock. When we say shock, well, when you say that someone's in shock, it's a critical condition that is brought on by a sudden drop in blood flow through the body. and generally that accompanies low blood pressure and low perfusion. So the circulatory system fails in some way to maintain adequate blood flow, decreasing the delivery of oxygen and nutrients to the vital organs. And something else people don't think about, Joe, is it also compromises your ability to remove waste. It compromises the perfusion of the kidneys and the kidneys' ability to do their job, as well as other removal waste systems that we have in our body. So it's not just a poor perfusion situation. It's complemented by the poor ability to remove the waste that we're producing. So let's start off with the four main types of shock. There's cardiogenic shock, which is basically an inadequate cardiac function. There's something called obstructive shock, which is an extracardiac obstruction to flow. In some way, the flow either into the heart, feeding the preload, or the afterload is in some way restricted or reduced by some type of obstruction. So that's an obstructive shock. Hypovolemic shock is basically when we have an inadequate amount of blood volume. It usually is due to hemorrhage, but we're going to look at the causes of that. And then finally, we're going to talk about distributive shock. And sepsis falls under this category of distributive shock. And they call it distributive shock because it is a redistribution of the blood volume in your system. And that's what's important. We're going to look at that and how that happens and why that happens. So let's talk briefly about the 4-1 so we can understand. Cardiogenic shock is a disorder of cardiac function, critically reducing the cardiac output. It's caused by a systolic or diastolic dysfunction, and of course that leads to reduced ejection fraction or impaired ventricular filling. So it might not just be that the heart isn't pumping very well, it may be that it's not filling well in the first place because of some other chamber not working well, like the atrium, for example, being in fibrillation. It's defined by a systolic arterial pressure less than 90 or a MAP 30 millimeters of mercury below the patient's baseline that they normally would have. And a cardiac index of less than 1.8 cardiac index without pharmacological support or less than 2 with pharmacological support. Now, in addition to these criteria, evidence of cardiac dysfunction is required. You must actually diagnose that together with the exclusion of other types of shock. So when we look at the cardiac dysfunction can be due to myocardial reasons, mechanical, or rhythmologic causes. So you have myogenic, which is acute coronary syndrome, basically some type of obstruction, blockage in the coronary that we see so often. And that's the number one myogenic cause. Cardiomyopathy, these can be in there, myocarditis, pharmacotoxicities, cardiac trauma. Then you can have a mechanical issue like a valvular disease or an intercavitary structures impending on the flow like a thrombus or a tumor. You can have a ruptured valve of some type, chordae tendineae, teared leaflet. Any type of valvular issue could be the mechanical reason. And then you can have any myriad of rhythmic issues, whether of some type of bradycardia issue or tachyarrhythmias. So that would be the main 3 categories that you would fall under if you had cardiogenic shock. So let's look at obstructive shock, and basically, as I said earlier, it's a condition caused by some type of extracardiac obstruction of the great vessels or of the heart itself. Mechanical intra or extravascular factors reduce blood flow in the great vessels or cardiac outflow. This results in a critical drop in the cardiac output and, of course, global perfusion. The result is a state of shock with tissue hypoxia in the organ systems. Okay, so obstructive shock is disorders involving impaired diastolic filling and reduced cardiac preload. For example, vena cava compression syndrome, something imposing on the vena cava so that you have poor return to the atrium, basically affecting your preload. You could have a tension pneumothorax, similar thing. pericardial tamponade is going to impose on the atrium themselves, pushing pressure on the atrium and a lot of times the right ventricle. And this is disallowing the blood that is coming into the IVC and the SVC. It's inadequate filling of the atrium. You can also have a similar situation when you have too high of peak. So that would be obstructive shock. So,
hey, John, may I interrupt? May I interrupt 1 second?
Yeah.
I'm sorry. Can you go back 1 slide? So, since we do a lot of ECMO, I have seen circumstances where we have had, the tension pneumothorax I've seen many, many times. But the vena cava compression syndrome, if you end up where you're putting a line in and you're anticoagulated and you get into the artery and you go through it and retroperitoneal bleed and your belly starts to fill up, you'll start losing your ECMO flow for this very reason. You basically are not draining the inferior portion of your body. I've seen that any number of times.
Correct. We see this in ECMO. It's not uncommon to have some type of GI bleed or some type of, like you said, retroperitoneal bleed, where you eventually, basically form pressure on the vena cava, and that's going to obstruct the return because it's under very low pressure. Anyway, it wouldn't take much pressure on the external vena cava to restrict and reduce that the size of the cava and the blood flow coming up back to the heart. So it's a pretty serious issue when that happens. And it definitely affects your ECMO ability to flow. So hypovolemic shock, looking at this one, it's a condition of inadequate organ perfusion caused by a loss of intravascular volume. The result, of course, is a critical drop in cardiac preload. You're not getting enough volume coming back into the heart, and therefore you have reduced outflow, reduced macro and micro circulation, inadequate tissue perfusion, of course, and metabolism, and the triggering of an inflammatory reaction can subsequently follow when you have this. You have inadequate organ perfusion due to hypovolemia, usually hemorrhagic causes, and it's usually used to a large blood loss. You can have a loss of circulating plasma volume, and it could be due to a fluid shift, but largely the fluid shift is going to fall under the next and last category we're going to talk about. So there's a little bit of an overlap between hypovolemic shock and distributive shock, but basically you could also have a fluid loss that doesn't have to do with hemorrhage. For example, you could be, completely dehydrated from excessive sweating, urinating, diarrhea, vomiting, and lack of fluid intake, a combination of those. So anything that's going to greatly decrease your circulating plasma volume, of course, is why it's called and falls under the category of hypovolemic shock.
Yeah, can I add to that also, John? I mean, this is such a broad topic, but I think this is an important concept for people to understand, is that if you are severely hypoalbuminemic, you can have hypovolemic shock due to third spacing of your plasma water volume and being hypovolemic intravascularly, but yet massively fluid overloaded extravascularly.
Right, and that's why they do include fluid shift here, because under hypovolemia, it does fall. Fluid shift is going to fall a lot on the next one, which is where septic shock falls in under our distributive shock. But it does fall here also for whatever reason. If you had a lot of fluid shifting out of the intravascular space, you're basically going to be hypovolemic in the intravasculature, which is where you end up, regardless of how you got there. Hypovolemia obviously is going to lead to a condition of shock and poor perfusion.
And what's so interesting about that is you can go the opposite direction, aggressively treat the hypoproteinemia, albuminemia, whatever the case may be, and reclaim extravascular fluid back into the intravascular space and put the patient into heart failure by fluid overload. So it can go both directions. Yeah,
you have to be very cognizant when you're talking about fluid shift especially massive, coming either out of the vasculature or reversing that and coming back in, either not aggressively enough or too aggressively. Yes, that's a good point, Joe. I wanted to go over the 4 types of shock so we could understand why we're calling, why septic shock is distributive shock, and what distributive shock means different from the others. So it turns out that distributive shock, which is kind of a strange name, but it's going to make a lot more sense, I hope, of why it's called that in a minute when we discuss this even further. So the most common type of shock, distributive shock, is a state of relative hypovolemia resulting from pathological redistribution of the absolute intravascular volume. See, now that's why they call it distributive. The circulating volume is not because of a hemorrhage. It's because it's being redistributed from the intravasculature to the outside the intravasculature. So the question is, why is that happening and how is that happening? And so this is what's interesting, is that you have a redistribution of your circulating volume to the outside tissues, where of course it is detrimental in so many different ways. But in the terms of shock, it leads to a low blood pressure, low perfusion state. Therefore, it creates a clinical picture of shock. So when we look at this now a little further, relative hypovolemia due to a loss of vascular tone or the fluid shift in the interstitium. So when you talk about loss of vascular tone, the volume is shifting within the vascular system. In other words, if you have a very narrow pipe or narrow blood vessel, and suddenly it's a very wide pipe or very wide blood vessel, that volume is still there, but now it's distributed into a much larger surface, much larger area. And it's not doing the job that it was once doing in terms of a lot of things, blood flow and blood pressure. But you also have fluid shift into the interstitium and distributive shock. And this is because of a disordered permeability of the vasculature. Okay, so the result of these two things, loss of vascular tone, i.e. vasodilatation, usually on a large scale, and permeability of the vasculature, largely the capillaries, which we're going to talk about, the fluid is distributed in a larger circulation volume, because your vasculature is so much larger, and to complement it even worse, some of the fluid is shifting out of the vasculature altogether into the third space. So the result is a critical drop in cardiac preload, right? Because if all this volume is being held up in the vasculature and moving now much, much more slowly, and it's being fluid shifted, you're getting very, very severe drop in your return of blood to the heart in your preload. So this drop in preload, of course, is going to be a real drop in cardiac output, which ends up being a reduced macro and microcirculation effect. So there's 3 types of distributive shock: septic, anaphylactic, and neurogenic. And if you go to the next slide, David, I just kind of highlight these two. The reason why distributive shock is the most common form of shock is largely because of so many different things that cause anaphylaxis. There's so many different types of anaphylactic reactions that can cause anaphylactic shock, which is a form of distributive shock. But septic shock and sepsis is also extremely common, all too common. So because of these two overwhelming factors, distributive shock is the most common form of the 4 types of shock that I've discussed. And now we're going to focus on the septic aspect of what for this lecture. So this is just a general chart, and I'm basically looking at the center there real briefly. And shock in general is an imbalance of the oxygen supply and the oxygen demand. And you can either because of poor output, like in a cardiogenic situation, and that basically is going to be because of some problem in the cardiac function, and so your output is poor, or you can have an obstructive problem that is basically obstructing the large vessels, either leading into the heart or out of the heart, and that, of course, is an extracardiac obstruction. And then, of course, you can have a volume problem. There's 2 types of shock that I just mentioned that are due to lack of volume, either hypovolemia, which is hypovolemic shock, because that's a loss of blood volume largely, most of the time due to hemorrhage. But then you get to the final one, which is the one we're talking about, distributive shock. Distributive shock is a shift of the fluid, not a blood loss and hemorrhage, but a shift of the fluid in the vascular space and without the vascular space, and therefore we end up with septic shock, and that's how you end up on that chart. So let's start it back a little bit further to make sure we bring everybody in. Well, what is an infection to begin with, and how do we get from a simple infection to sepsis and then septic shock? Because that is what the sequence would be. So an infection basically is the consequences of an invasion of an organism by a disease-causing agent, a pathogen. And it's a result of that pathogen entering our system and rapidly multiplying, which they are incredibly capable of doing, and they do. Then they release toxins. We're going to talk about these toxins that they release. So they enter the body, they rapidly multiply, they release these toxins, and then you have the reaction of the host to this infectious agent and the toxins they're releasing. So this is caused by a wide range of pathogens, prominently bacteria, but it can also be caused by, as we all know, viruses and fungi. And now an infection, when you say an infection, most often it's a localized infection, right? You have a sinus infection confined to the sinuses, a sore throat confined to that area, or maybe just have a cut in your finger and your finger gets red and infected, but it's contained to that area of the end of your finger. So most of the time, it's a localized infection, and basically our body is able to surround it, attack it, and get rid of it. So something else happens when a localized infection eventually becomes system-wide. So let's look and see what is sepsis now. So, well, sepsis, when you tell somebody, the person is septic, what they're trying to tell you is that the person has got actually beginning to experience an organ dysfunction, and it's a result of a dysregulated host response, systemic-wide host response to an infection. This is what separates sepsis from an uncomplicated infection. When somebody says the person has an infection, okay, you understand that they've been an invasion of a pathogen. When someone says they have sepsis, now we have this widespread systemic, dysregulated host response to the infection, and it's causing organ dysfunction. So the incidence of sepsis, however, is expected, by the way, to increase going forward because of our several reasons, but one big reason is we have an increasing elderly population who is at higher risk for sepsis. We also have an increased number of people living with chronic diseases, cancers, all kinds of COPD, all the things that have happened to people, and we're able to continue to manage people a lot longer with these chronic diseases, cancer, for example. So we have people living longer with chronic diseases at higher risk for sepsis. And then, of course, anybody who has immunosuppressive therapies, and there's more and more people who are living with, recipients of organs and other things that are living a lot longer now. So all these three populations are growing. Now, as you said, Joe, it's a very high incidence of septic shock, and 30% of people who develop sepsis, 30% of those people will develop into septic shock, which is pretty scary. Let's look at now what causes sepsis. Well, most of the time, it's a common infection. You can have, like I said, some type of localized infection. Usually it's a pretty serious one, like pneumonia is one of the most common ones, intra-abdominal infections, genitourinary infections. These three categories of infections are the most common likelihood for them to lead to septic shock. And the gram, very commonly, it's a gram-positive organism. It's also quite common that it can be a gram-negative organism, and I've listed a few of the ones there that are the most common, like Escherichia coli, Klebsiella, Pseudomonas. And then, of course, you can have sepsis caused by fungi and viruses. And I know, Joe, if you've seen enough ECMOs, you've seen people who have sepsis that are due to fungusemia. And you've also seen viral sepsis, of course, which we've run into with COVID, of course. And those are very difficult to treat. So how do we get to this nomenclature of septic shock? Well, the word septic comes from the word Latin meaning something rotten, or the word rotten. So basically, that's insinuating that we have an infectious pathogen in our system, something that is not sterile, and it's invaded us. And then shock, when you say somebody's in shock, this insinuates that somebody has a serious drop in blood pressure, i.e. a drop in blood flow, and of course, all that is equating to a drop in delivery of oxygen perfusion. So now let's look at the meat of the matter, and let's look at septic shock. So sepsis with profound circulatory and cellular metabolic abnormalities. So somebody can be in sepsis and not be in septic shock. They're dealing with a widespread infection, but they haven't developed severe drop in blood pressures, severe organ dysfunction, and all the things that go along with that. But when you have profound circulatory abnormalities, generally leading to vasodilatation and volume shifts and drop of blood pressure, but then it begins to affect your function of your cells and your tissues and your organs. So feared complications in septic shock are that it could lead to multi-organ failure, and it leads to hemostatic derangements leading to DIC, which we do see in septic shock. Now, the mortality, Joe, I think you mentioned something in the 30s. Depends on what you read, but almost every paper will fall somewhere between 30 to 50% mortality for septic shock. And septic shock accounts for 33% of all in-hospital deaths. That's pretty remarkable.
Yeah, I actually thought that the mortality was closer to 60% for septic shock, but you know, I do believe it has improved. There was a time when it was almost certain death if you developed septic shock. We saw a lot of DIC back in, you know, maybe a couple of decades ago or longer, but it has certainly improved. But still, 30 to 50% mortality for that diagnosis is quite significant.
Yeah, you know, it looked like we were making some headway on this, but with the aging population, the three things I listed here, the aging population, the number of people living with chronic diseases, and then the immunosuppressed population, we're actually losing our grip on this, and it's getting actually where the mortality is actually starting to increase again. From a lot of the research I did on this topic. So the risk factors, which I've touched on a little bit, chronic disease, immunosuppression, anybody with prior organ dysfunction, by the way. And another big factor is delay in diagnosis or treatment. You know, this people dragging their feet to come into the hospital because what we saw with COVID, but there's other reasons. Sometimes, you know, pre-COVID, people just lived in a very, very remote area or thought that they could deal with it at home, and they come into the hospital really way too late. So delaying them coming in or delaying us diagnosing it properly is actually a pretty big risk factor for somebody going from sepsis to septic shock. And of course, I mentioned the elderly as at risk for. So what is the septic shock pathophysiology? So patients over the age of 65 with immunosuppression or underlying malignant disease are disproportionately affected. Now, in some patients, the inflammatory response is either very small or non-existent, which is why not too many years ago, when people would come into the emergency room, one of the key diagnoses for septic shock was they had to be in a systemic inflammatory response in SEERS. That's not necessarily always the case. So that became not necessarily a part of the clinical diagnosis for septic shock, because there's a certain number of people, like I think you said that earlier too, Joe, where you are in sepsis, but you don't necessarily appear fully as though you're in sepsis. Was that you were touching on in the intro?
Well, yeah, it was, but I was also talking about patients who have a septic shock presentation, but they're not septic.
Right.
They don't actually have sepsis, but they have their presentation is septic shock like.
Right. You can have septic shock without a pathogen. And by the way, septic shock syndrome without an invasive pathogen. And by the way, we see that when people have ECMO, and sometimes you have with vasoplegia, where the person is in shock and they have massive vasodilatation that's unresponsive, but it's not because of invading pathogen. It's because of the massive inflammatory response.
Mm-hmm.
So let's look at this a little bit as to what's happening. So generally, you would have a pathogen. To get to septic shock, it does depend on the pathogen load that you're exposed to and the virulence of that particular pathogen. That's a factor. And then it depends on the host, the person themselves, the genetic composition and any comorbidities that they may have. That plays a huge role. But when these two things come together unfavorably, you can end up with a complex, exaggerated, and prolonged host response to the infection that evolves over time. And this is how we have evolved to a condition of septic shock in general terms. Look at this a little more specifically now. So as I mentioned, septic shock is distributive shock. We have a golden nugget slide here. It's relative hypovolemia resulting from pathological redistribution of the absolute intravascular volume. Now, what's happening and why? The core of the pathophysiology, and why this is a gold nugget slide, the core of the pathophysiology is the endothelial damage that occurs and the subsequent dysfunction. And this is what's going to be the real focus of my talk here today as we go forward for the remaining of the lecture. The endothelial damage and what's happening there explains almost everything that we see manifesting itself in the patient. That's why I made this slide special. So this endothelial damage and then the subsequent dysfunction of the endothelium leads to the dysregulation of the vascular tone. It leads to the vasodilatation, the massive vasodilatation we see. It leads to this impaired distribution of the volume that I'm talking about, i.e. the volume shifting. And this poor functioning damaged endothelial layer causes and allows inordinate amount of vascular permeability, which is another reason why this fluid is being redistributed to the tissues. So it begins to explain a lot, the endothelial damage. So dysfunctional endothelium causes a variety of pathologies. It causes the hypovolemia, it causes the vasodilatation, and by the way, it also causes organ dysfunction, but I want to point out that it causes specifically mitochondrial dysfunction and i.e. leads to impaired cardiac function. And Joe, if you've ever witnessed somebody in septic shock, a lot of times they're struggling with their cardiac function and their cardiac stroke volumes, and their hearts are sluggish, although they didn't necessarily present with any type of cardiac abnormality. This endothelial damage and the things that subsequently happen have a direct effect on the mitochondria of the heart and decrease the cardiac's ability to function while you're in this septic shock state. And then, of course...
Go ahead. I'm sorry. Go ahead. I'll bring it up.
A damaged endothelium is going to lead to coagulopathies because the endothelium is what's maintaining our homeostasis for our blood not to clot intravascularly, right? So damaged endothelium is a big negative and a big causative factor towards our blood now thinking that it needs to clot because it's coming in contact with something other than the endothelium because of its damage. So let's take a look at this. So Joe, I actually handmade these graphics. I had to hand make these to explain what I wanted to explain. There was nothing I could steal online to make this my point. So septic shock pathophysiology is what I really want to spend some time on here today. And I put a little note there in the upper left, and so you can follow the sequence here I say phase one, basically the first phase of what's going on, and it's going to progress phase 2, 3, 4, 5, and so on. So we can see how this is cascading from an initial standpoint into a endpoint standpoint where we get to severe septic shock and organ dysfunction and multi-organ failure, perhaps. So phase one is a pathogen invades the circulation. All right, I think if you go to the next slide, I think you'll see that. Now, normally when we get exposed to a pathogen, as I said earlier, it's a localized infection. Let's just say, for example, you get a cut on your arm or on your finger. Now, the pathogen has broken through and made its way past our protective barrier, the skin. And in the process of you getting cut, the reason that you're bleeding and things like that is you've cut a number of capillaries along the way, and the pathogen is now in the tissues, but the capillaries have been cut. And so as you see the blood coming along, you see red cells, platelets, and there's an occasional white cell. And by the way, the white cells only make up 1% of our total blood volume. And so normally the pathogen is really in the tissues, and the capillaries that have been ruptured are going to bring in some white cells, and they're going to be kind of in the tissue level with them, and the pathogen is going to be kind of isolated, surrounded by the white cells, and then this is why you have a localized inflammation and a localized infection, and the white cells are going to be able to recruit more white cells, surround it, and get rid of the infection right there in the localized area. But when you see them, in the blood vessel, like I'm showing here, this now is something that we are not terribly equipped to handle from an immunological standpoint. So here it is, we have pathogens that invaded the blood vessel by one means or another. And indwelling catheters, Joe, needles, punctures, and localized infections that can get out of control and make their way into the blood vessel as well. There's many ways, though, that.
Yeah, collapsing. So that's how common is that now? Yeah,
right. So go ahead to the next slide, and we'll see that now the blood has come in contact with these pathogens, and what's basically happening is, the red cells go on their merry way, and the platelets go on their merry way, but the white cells are on the lookout for these pathogens. They immediately will bind to the pathogens and seek to destroy them. And this is a little bit of a complicated thing, but what happens is these white cells immediately release a host, and there's a pretty decent list of chemotoxic agents, and I've put a few under there. This is not a comprehensive list, but number one is they release cytokines. They release leukotrienes, peptides, complement factor, even platelet factor 4 is released, and these white cells immediately think to themselves, I'm outnumbered. That's their immediate reaction. If one white cell comes into contact with one pathogen, it immediately believes it's vastly outnumbered. Like you're in a war, you want to fight 10 guys against 100, or do you want to bring in 1,000 more on your side and now fight 1,000 against 100, right? So their immediate reaction is to recruit as many white cells as they can. So immediately releasing these chemotoxic agents which recruit white cells. So you have a vast recruitment and even additional production by our body, by the way, and release of additional white blood cells. So your normal range of white blood cell count is about 4,500 to 11,000. And what's the first thing that people look for to identify that somebody has an infection is an elevated white cell count. And this is why, because your body immediately wants to elevate the white cell count to outnumber the white cells, need to outnumber the pathogens. Now remember, the pathogens are reproducing very quickly. We're going to talk about that. So step one, the pathogen comes in. Step two, the white cells come in contact with the pathogens, and they go into an immediate recruitment and release of a number of chemotoxic agents. Okay, so let's go on to the next step. And so now, the bacteria, let's just say the pathogen happens to be a bacteria, they are generating and releasing at all times endotoxins or exotoxins. Okay, now the exotoxins are an ongoing, and they're generated and actively secreted by these pathogens. Okay, the endotoxins remain inside the bacterial membrane, and they're released as a last dying stitch effort. The endotoxins are released only once the pathogen is being killed or is dying. So these things are so noxious that they continue to release these toxins as they're moving around the system, and then they have one last one that they release that they keep inside their membrane for when they're killed. So now you have the white cells releasing all these chemotoxins, and then the toxins are releasing all of these toxins into the system. Okay, so now let's move to the next step of what happened. So let's just take a quick look, though, Joe, at a real-life photo picture, microscopic picture of our endothelium. And one thing that people, we've talked about on our shows before here, but a lot of people forget about the fact that we talk about the endothelial cell, but the endothelial cells have this lining of an endothelial glycocalyx, which is multitude of these fine hair-like projections that come up from the endothelial cell. And it's this glycocalyx that's really doing the large majority of the work of why the endothelial layer and the endothelial cells do what they do. And as you can see here, they're negatively charged. And a lot of the plasma proteins and platelets are positively charged. And just to get off the subject for a little bit, Joe, if you look back about 20, 25 years ago, when all of these bio-coded circuits were coming about and people were trying to come up with bio-coded circuits for our perfusion circuit, largely what they were basing their efforts on was to negatively charge the fibers of the oxygenator and the tubing and act as if it was endothelium by repelling the coagulation factors from adhering to the tubing and to the fiber surface. Did you have a comment?
No.
Okay, so this kind of like gave the premise of why the tubing manufacturers, what they were trying to do and the reason why they were trying to do it, because you're not going to duplicate the endothelium, but you could sort of mimic one of the large effects of the endothelium, which was to repel the positively charged, platelets and plasma proteins and so on, and therefore you'd have a lot less procoagulant surface. So going back now, so what I wanted to show this was that when you have these toxins being released by the pathogen, this glycocalyx the glycocalyx surface is very, very vulnerable to these insults. These are not durable, tough guys. These are very fragile things. And in addition to the toxins being released, which are very damaging to the glycocalyx, the white blood cells' mass release of cytokines and chemotoxic agents, they're also very sensitive to that. See, the body was really set up to fight localized infections. If you have a localized infection, the white cells surround it, they keep the toxins limited to that isolated area, and then they get rid of the toxins on that isolated area. But now, when it's systemic wide and it's in the bloodstream, and you have now a mass release of toxins and a mass release of cytokines, the endothelium was not prepared for that level of insult. So the pathogens' mass release of endotoxins and the white cell cytokines leave the endothelial cells themselves unprotected, because it wipes out and gets rid of this glycocalyx lining and leaves the cell itself. I think the next slide, I kind of just circled the endothelial cell itself is right there, will become exposed directly without the glycocalyx there to protect it to these toxins, right? So this kind of gives you a real bird's eye view of what's happening on the endothelial level. So now when you've got destroyed glycocalyx, it's immediately going to result in damaged endothelial cells. And by the way, the glycocalyx is part of, and a very big part of, the endothelial cell itself. So a gold nugget slide, what I want people to understand, the linchpin to septic shock is all about the destroyed glycocalyx and damage to the endothelial cells. This is where the rubber meets the road. This is the first and most important pathophysiologic domino to fall. And you're going to see why this leads to so many of the things that we see in septic shock. So septic shock, pathophysiology of the tissue hypoxia cascade. How does all this, what I've just described so far, we have a pathogen that's invaded, the white cells do their job, they release chemotaxis agents, and then the toxins are being released by the pathogen. How does that lead to tissue hypoxia, which is what we see in septic shock? Well, I'm going to talk about each one of these individually, but all three of these occur simultaneously. But let me attack one at a time. Next slide, you see I'm going to highlight that we're going to talk about clot formation and capillary obstruction. Now, I'm going to talk about all three of these, but they occur simultaneously. So let's talk about clot formation and capillary obstruction, because we're talking about how do we get to tissue hypoxia from a pathogen invading our system. So here we have a cytokine storm there I've circled, and you have all of the cytokines coming in from release of the white blood cells. And then you have those bacterial or pathogen endotoxins. These are insulting and attacking the endothelial cell. And these endothelial cells are so damaged and so fragile that they actually will detach themselves as they die off from the surface they're attached to, which largely is collagen, by the way. So these endothelial cells now are actually being stripped off the lining of the blood vessel because of these toxins. So now what you see is you have damaged endothelial cells that have now left their post, and basically what's underneath them is just the supportive structure that's holding the capillary and the blood vessel together, which is largely collagen. Well, what's going to happen when you have collagen exposed to the blood? Go ahead, Dave. You're going to have platelet activation. Platelets come in contact with collagen. They think they're out in the tissues. They think they need to clot. So you have a large amount of platelet activation. Now remember, this endothelial damage is happening system-wide. The pathogens are systemically wide circulating, releasing toxins. The white cells are chasing them down, releasing cytokines and so on. So I'm showing one single spot here, but imagine it on a very large scale. So massive platelet aggregation, forming clots and platelet plugs where the endothelial cell used to be. So here I have my own personal drawing again. So let's look at the capillary, Joe. As you know, the capillary is big enough just to pass a single red blood cell. The red blood cell is coming through the capillary, and lo and behold, you have a section of completely damaged endothelial wall. Right? Go ahead. So, but unfortunately, the red cell cannot continue to pass through the capillary because the platelets have plugged it up, as I just showed, because of the collagen that was exposed on the missing endothelial cell. So here is a completely clotted off capillary. And Joe, you know, you've shown that slide a number of times with the flow monitor, the microvascular flow monitor that you used.
I was thinking about that.
Right. And there were some great examples of capillaries that were being fully perfused, and then all of a sudden areas where the capillaries were basically not even, they were like they were shut down. There was no blood flow through them, right? It was for different reasons. But that comes to mind when I think about that you're basically shutting down the flow of the capillaries.
Yes. And this is your DIC. This is your DIC pattern. And then eventually you have a consumptive coagulopathy, and then all of a sudden you're bleeding from everywhere because you've used all of your clotting factors up.
Exactly where we're going with part of this. So looking at tissue hypoxia, though, so how did a pathogen cause us to be poor perfusion? Well, damaged endothelium begins to clot off with platelets, and not only with capillaries, by the way, this could happen in small blood vessels as well. The blood vessels, pretty small blood vessels leading to the capillaries, they're all getting endothelial damage as well. All right, so this is one big thing that's happening. So systemic-wide damaged endothelium stimulates massive platelet adhesion, subsequent clotting, resulting in exactly what you just said, Joe, consumptive coagulation factors. Fibrinolysis, by the way, is going to follow whenever you have intravascular coagulation. The fibrinolytic system is activated simultaneously, and then you can result in complex coagulopathies and possibly DIC, and by the way, likely DIC if this is severe enough. So now let's look at the second one I talked about. So we have capillary obstruction, clot formation, leading to tissue hypoxia. What about another thing that's going on due to the endothelial damage? Vasodilatation, resulting in decreased blood flow. Let's look at that one. So here again, we have blood coming down a modestly sized, small to medium-sized blood vessel. And lo and behold, we have damaged endothelium there. Well, the damaged endothelial walls, normally release the appropriate amount of nitric oxide, maintaining our vasomotor tone, right? You always have things in our system that is a yin and a yang. The nitric oxide that's being released by the functioning endothelium gives us our vasomotor vasodilatation, and then you have counteracting things that give us a modest amount of vasoconstriction. So we're in a homeostatic balance of the natural normal size of the blood vessel. Well, in this case, the damaged endothelial walls now completely have lost their ability to regulate the proper amount of nitric oxide being released, and now mass quantities of nitric oxide are being released from this damaged endothelium, and this is a powerful vasodilator in the microvasculature. So you have massive amount of nitric oxide being released, so all of a sudden our blood vessel is now much, much larger, much more dilated. So if you see now what's happened is, in the last slide, there was only 3 rows of red cells, but they were moving through very quickly. Now you have 8 or 9 rows deep of red cells, and they're moving very slowly. You see, because it's the same amount of blood flow, but now you have a massive, larger circulating pool. It's like if your venous system is a capacitance system, right? If you have a dilatation of your venous system, you're going to have massive pooling where the blood is there, but moving very slowly. So what happens is mass pooling of blood in the macrovasculature is going to greatly decrease your preload. The blood is not making it back to the atrium very swiftly at all. If you don't have good preload, if your CVP goes from 8 or 10 to 1, that means very little blood is coming back to your atrium, but it's all pooling in your vasculature because of this nitric oxide. Severe drop in perfusion, severe drop in delivery of oxygen. So mass nitric oxide release causing powerful vasodilatation in the microvasculature. And this is what's called as a volume shift in distributed shock. The volume is shifted within the vasculature in a much larger system now, right? It's the same amount of volume, but it has a much larger space now in which to occupy. So let's look at the third one. So we have capillary obstruction clotting off our capillaries and small vessels. Then we have massive vasodilatation, which is a greatly decreased amount of blood flow through those larger vessels. Let's look at edema and decreased gas exchange, which is the result of edema. So this damaged endothelium, it causes increased capillary permeability. Capillary vessels need to be permeable normally to allow the movement of fluids. This happens on a regulated basis, a controlled basis. An increase in capillary permeability is often seen as a result of the inflammatory process. This happens, when you have an inflammation. Basically, why does your cut finger get all red and inflamed? Because you have fluid accumulation, you have blood going to the site, and you have the toxins being released there, but you also have increased capillary permeability, which is why you have swelling largely. The cytokines, the interleukins, the free radicals, the complement, all of these things are a result of what happens when you have increased capillary permeability. Now, the third spacing itself is frequently observed in a number of conditions: burn, injuries, trauma, pancreatitis, and now, as you see, in sepsis because of the damaged endothelium. So what is the problem with this? Why is this even a problem? Well, let's look at a normal capillary blood flow or through a blood vessel in general, but let's look at the capillary microcirculation. You have blood coming through, and you have the normal amount of hydrostatic pressure. The normal pressure in the capillary is going to force some fluids to pass through the capillary membrane, and then you have the osmotic pressure, being the protein levels much higher in the vasculature than the tissue, is going to bring that fluid back over because of osmosis, and the interstitial fluid remains balanced. And as it exits the capillary through the venous end, you basically have a normal tissue situation where you're not walking around every day dehydrated in your tissues, nor are you walking around edematous because of this balance of the hydrostatic pressure pushing fluid out and the osmotic pressure bringing it back in at an equal rate. What happens in sepsis, though, is that you have this capillary permeability increase. Well, now you have a large amount of fluid moving out into the tissues. And so you have a great increase in your interstitial fluid, i.e. edema and swelling, right? You see this in patients all the time. Well, why is that a bad thing? So let's look at the drawing that I made up for this. You have your blood cell coming through a capillary, and there's your tissue cells right on the other side of the capillary. And that's all fine and good. And normally, you're going to have gas exchange. You're going to have a freely moving oxygen leaving the red blood cell into the tissues and carbon dioxide being transferred back into the red cell. And it's a very nice, smoothly moving system to perfuse our tissues. Well, when you have increased capillary permeability and a lot of fluid now, plasma water, is being sent out through the capillaries or being allowed to escape through the capillaries into the tissues now because of this damaged endothelium and increased capillary permeability, what happens next is you have all this fluid that's now accumulated that is now, by the way, obstructing the ability of gas exchange, because normally the CO2 and the oxygen doesn't have to perfuse through this massive amount of layer of fluid. It's basically able to access the cells. So now you have a very much inhibited ability for free gas exchange to occur at the tissue. So here again, hypoxia because of capillary permeability leading to a fluid shift into the tissues, obstructing the pathway of a gas exchange, leading to tissue and organ hypoxia. So let's just talk about for a second, because I mentioned it earlier, the myocardial dysfunction, which is in of itself a separate thing. And by the way, Joe, you could spend so many hours on this topic, because each organ, by the way, is detrimentally affected by sepsis. But I just wanted to focus a little bit on the myocardium for our topic here today. And this cardiac dysfunction due to severe sepsis, you're basically going to see impaired contractility, diastolic dysfunction, reduced cardiac index, reduced ejection fraction, all the things that are classic of a poor cardiac output. And this cardiac dysfunction, though, I mentioned that each organ is struggling due to hypoxia and all the things I just mentioned. But when the heart begins to dysfunction, this is a additive aggravation to the other organs, because you need this circulation to this heart is the pump, right? It is the additive effect that leads you to multi-organ failure, because with a poor functioning heart, you have that much worse perfusion on top of the things I already talked about. Septic patients with either systolic or diastolic function or both have a higher mortality than those diagnosed with sepsis that do not have a diastolic or systolic dysfunction. The mechanisms that underlie myocardial depression during septic shock are actually not all that well known. There's just things we don't know exactly of why this is happening. So just going on with this a little more, the circulating inflammatory cytokines, the interleukins 1, 8, TNF-A we talk about a lot, which are increased during septic shock. These cause an altered production of the nitric oxide, but also they alter the calcium homeostasis. And all of us know calcium is absolutely vital to the inotropic effect of the myocardium. You have the impaired beta adrenergic signaling, right? Your beta signaling is impaired, and that's going to lead to reduced cardiac contractility. So altered calcium homeostasis, impaired beta signaling. Cardiac dysfunction is a consequence of impaired metabolism, and also reduced energy production in the cardiomyocytes. So now you have the ATP ability to produce being decreased also. So pretty serious impact on the myocardial cells here when you have severe sepsis. So it's a little bit of a busy slides, but I'm going to put it up one at a time. There's 5 stages of overlapping sepsis cascade. Okay, it starts with the Sears response and progresses to multi-organ dysfunction, if not appropriately compensated by something called CARS, which, Joe, I think you might have mentioned that the other day in your talk. The compensatory anti-inflammatory response, which a lot of people don't talk about. We always talk about SEERS, is the systemic inflammatory response, but for every reaction, there's usually a counter reaction, right? Well, the body has something called CARS that also, by the way, kicks into gear simultaneously with the SEERS response, and that is an attempt to modulate and to temper down the SEERS response. Okay, so stage 1 is a local reaction to the site of injury, like I mentioned, and the reaction of the body is attempting to contain the injury to limit the spread. Leukocytes release cytokines, and the whole process goes into a local inflammation, vasodilation of the local area by nitric oxide. Endothelial cells allow white cells into the tissue to try to surround the invading organism, and you have swelling and you have pain, and the area feels hot. Well, stage 2 is when the CARS system, the compensatory anti-inflammatory response syndrome, attempts to maintain the immunological balance. There's a stimulation of growth factors and recruitment of macrophages and platelets as the level of pro-inflammatory mediators decreases to maintain homeostasis. Now, when the scale tips towards the pro-inflammatory SEERS response, resulting in progressive endothelial dysfunction, which is why I focused on that, and the activation of the coagulation pathway, which is why I focus on that, it results in end organ microthrombosis, as I demonstrated, and capillary permeability, as I demonstrated, and eventually resulting in loss of circulatory integrity. Now, if the CARS response can keep the SEERS response in check, people basically do not go into sepsis or septic shock, and they get over the infection. It's when the tipping of the scale and the SEERS response greatly outdoes and outnumbers and outweighs the CARS response that you get into what we're talking about. Stage 4 is characterized by later in the stage of this, where it actually does overcome the SEERS response. However, this results in a state of relative immunosuppression. When the CARS response finally does overcome, which, by the way, does happen in nearly every patient, if the patient is going to survive this, at some point the SEERS response is very tempered down, but the CARS response now has become dominant. And this actually puts the patient in a state of relative immunosuppression. And therefore, the individual now becomes susceptible to secondary or nosocomial infections, thus perpetuating the sepsis cascade. Step 5 now manifests itself in the multi-organ dysfunction. The MODS with persistent dysregulation of both the SEERS and the CARS response, seesawing, one's winning for a while, the other one wins. They both have their negative effects when one dominates too much over the other, because normally these are in balance. At the cellular level, noxious stimuli, like I said, from cytokines, as well as the endotoxins produced by the pathogen, activates a multitude of things, as I mentioned, and this is going to cause your organ damage, back to coming full circle on that. So let's look at real
Surviving
quick. This
sepsis,
was not the focus. wasn't the focus of my lecture was the diagnosis or the treatment, but I wanted to hit on it briefly. Somebody comes into the emergency room. There is something called the Surviving Sepsis Guidelines. Basically, you need to identify the presence of an infection or suspect an infection. You may not have it diagnosed, but you suspect an infection, and two or more of the following criteria: hypotension, systolic blood pressure less than 90, or decreased 40 from the baseline, a MAP lower than 70, and a lactate greater than 1. So you used to have a presence of an infection or suspicion, and combined with at least two of those three things in addition to that. Also, according to the sepsis guidelines, you need to look at the presence of an infection together with systemic manifestations. So the person comes in to the ER and they're tachypnic, they're breathing rapidly, or, by the way, they may not be breathing all that rapidly, but on a blood gas, their CO2 level is less than 32, shows that they're hyperventilating. White blood cell count, either less than 4,000 or greater than 12,000. Those two things we can talk about. Sometimes you have an initial drop in your white blood cell count, but most people are going to come in with an elevated white blood cell. You're tachycardic. Why are you tachycardic? Because you're vasodilating. Your heart's trying to compensate for your drop in blood pressure, and also you're becoming hypermetabolic. Your temperature is spiking above 38, or counterly, you could have that below 36, would also indicate that something very serious is going on with your dysregulation. So the treatment, very complicated, but there's a simple, something very, very powerful and very important to any clinician, critical care medical doc that treats sepsis patients, something called the 3-hour sepsis bundle. These are things that when someone comes into the emergency room, these things must occur within the first 3 hours. And by the way, it's actually been changed to a 1-hour sepsis bundle because the sooner has a much bigger impact. But within 3 hours of the person walking to the ER, suspicion of sepsis, you need to obtain a blood culture, obtain a lactate level, administer broad spectrum antibiotics before you even get that blood culture back. Get broad spectrum antibiotics, get them started, and administer 30 milliliters per kilogram of crystalloid fluid. This is because of the shock and because of the drop in blood pressure the patient is feeling. This 30 milligrams per kilogram is a very tried and true technique that people need to get that general amount of fluid. Now, it does get a little skewed when you have very high BMI patients and very obese patients. You can't quite go by this exactly. That would be one of the exceptions to the rule. But when people are vasodilated in shock, they need that volume because of the vasodilatation. Now, there was a study I just want to talk about on this sepsis survival campaign, the 3-hour guideline I just talked about. Prunelli and her colleagues, I believe it was her, but there were a whole slew of PhD RNs on this article, too many to list there. And they did a very comprehensive study on the effectiveness of the people getting all of these 4 treatments in that first 3 hours and the impact. And if you didn't get it within 3 hours, what was the impact? And from January 2011 all the way through the middle of 2015, this study encompassed 6 hospitals and 45 clinics in the Midwest area of the United States. Over 5,000 patients with severe sepsis or septic shock were in the study period. There were 1,412, or nearly 28% of the patients, who died in the hospital. Now, the majority of these patients had all 4 of the 3-hour bundle recommendations done within the 3 hours. However, from the 214 patients who did not receive any of the recommended actions within the 3 hours, 41% of those people died. So just in general from this article, if you look at the dotted line, that's the mortality on the left, and the delay in getting the 3-hour bundle completed along the bottom. The dotted line shows the longer you delay and don't get around to this treatment in the 3-hour bundle protocol, the mortality goes from roughly about 30%, where everybody starts, up to about 45%, but the patients who got the 3-hour bundle, they had a decreased mortality of about 28%. So a difference from about 45% if you didn't get treated properly in those 3 hours to down to 28% mortality if you did get that 3-hour bundle properly. So now we're going to go on to the gem of the week, Joe. This episode's gem of the week is going to be something very interesting that just came out 2 days ago. I discovered this. Dr. Sederwick just published this in Psychology Today on their online version of Psychology Today. Just came out in 2022, February. They've discovered a striking link between your vitamin D levels in your blood and the Omicron and other COVID-19 variants. Let me show you what we're talking about here. It's fascinating. In his article here, he talks about that low levels of vitamin D in your blood are associated with the severity of the Omicron and all the other variants, by the way. It wasn't specific to Omicron, even though that was in the title of the article. It had to do with all variants. They found a striking differences in the chances of contracting severe COVID-19 between individuals with sufficient levels of vitamin D prior to catching the virus and those who did not have sufficient levels of vitamin D when they caught the virus. Half the vitamin D deficient people developed severe life-threatening illness compared to just under 10% of those who had normal levels of vitamin D. The study is the first to examine existing vitamin D levels in the people before they contracted COVID. This is a quote from the article, Dr. Sederwick's quote. "We found it remarkable and striking to see the difference in the chances of becoming a severe patient when you're lacking in vitamin D compared to when you are not lacking the vitamin D." They're going to be a little more specific here. 253 people were admitted to a hospital between April 2020 and February 4th, 2021, a period of time, by the way, that was before Omicron appeared, but they discovered later that they did have plenty of Omicron patients in their cohort, as it turns out. We didn't know that it had been announced during the time. The results were equally relevant for Omicron as well as for previous strains. Didn't see any difference in this. Vitamin D is largely synthesized naturally in human skin and requires direct exposure to sunlight, specifically ultraviolet B light. Now, artificial light under a sun lamp, no matter how good or how high the quality, isn't going to cut it when it comes to manufacturing vitamin D. Now, what's happened is the pandemic has kept many people indoors for nearly 2 years. A considerable number of individuals may have fallen below the threshold for adequate vitamin D levels, which conventionally is supposed to be about 20 nanograms per milliliter in your blood. And by the way, you can get this tested and they can tell you what your vitamin D level is. New data indicate that the 20 nanograms per milliliter is too low. A minimum level is now recommended of 50 is now advised. Levels below this cause weak innate immune responses, they've discovered. Now, what's the vitamin D guidelines? Diet plays a small role in vitamin D intake. It is found in a number of foods, but by the way, they're not very high levels even in these foods. Fish, mushrooms, egg yolks, full-fat yogurt, beef liver, and duck have vitamin D. Not a lot, by the way. It's recommended, the guidelines recommend that we take 2,000 IUs or 50 micrograms of vitamin D daily, but do not exceed 100 micrograms a day. You can overdo it, by the way, in vitamin D because your body stores vitamin D. Now, individuals who get little or no sun exposure, people with a body mass index of greater than 30, these are all people at risk for low vitamin D. If you have obese patients, by the way, have typically a low vitamin D level, which, right, Joe, haven't we seen that obesity is definitely a very high comorbidity when it came to COVID?
It's huge.
Huge, right. Now, if you never get out in the sun, you might have a risk of low vitamin D. If you have a BMI greater than 30. Now, dark-skinned individuals the pigment in their melanin actually reduces the skin's ability to make vitamin D in response to sunlight. Vitamin D is a fat-soluble vitamin. Your body stores it for months, and you don't necessarily need it every day. What we mean by that is, because the top of the slide says, take it every day. Your body stores it. If you skip or miss a day or two, you don't need to be in panic mode. Your body stores it, and it's going to release it. The stores are going to be released, keeping your levels higher. Now, you can have vitamin D toxicity, but you have to take pretty extreme large doses of vitamin D every day for quite a while. But it is not a good thing to get vitamin D toxicity. So, in conclusion, guys, there's the website again to reach out to me if you want to contact me about email questions, comments, suggestions. I'd love to hear from you guys. And I think we're ready for our panel discussion. So that's a lot of information, Joe. What do you think?
That was an excellent overview of sepsis and septic shock. And of course, you would need several hours, I think, to go over everything that you would have to really understand it. And even then, I don't think you could. The treatment, there's been so much done with this, and so in interest of time, everyone that's watching and so forth, I'm going to schedule a session on the treatment for septic shock, because giving fluid administration, of course, you can go all the way back, and I've mentioned Schumacher before and Rivers before, and these guys that have been treating sepsis with increasing DO2 to supranormal levels in these patients to try and manage this. And of course, you started talking a lot about the third spacing problem that occurs and the organ dysfunction that's secondary to that. And of course, as you see the patient, you've seen that slide from the other day with that patient that was all swollen. Well, the organs look like that too. So a lot of the mitochondrial damage you were talking about in cardiac function, but you get myocardial edema as well. You get renal edema, you get hepatic edema, you get pulmonary edema, you get generalized tissue edema. And so you lose your oxygenation capability, your O2 delivery, if you will, going to the tissue. So you start starving the tissue of nutrients, and you start increasing the fluid volume even more. And it's just a horribly, it's a horrible cascade of reinforcement to itself, bad reinforcement to itself. One thing leads to another, which leads back to the other, and keeps going around in a circle. Of course, you have to worry about, your protein levels in your blood. Capillary leak syndrome is dreadful, because now you not only have fluid leaving or water leaving, you have proteins leaving. And if you treat that with albumin, you can find yourself in even more trouble, because your proteins are leaking out into the interstitium, and that's another cascade. I will say this. I don't know if you saw the article or not. I'm going to dig it out, and I think we need to do this topic again in terms of the treatment. But they're actually beginning to advocate the use of ECMO for severe septic shock. And that's to, manage the circulatory flow problem that you have when you have this massive vasodilatory effect. You have this preload problem. You have cardiac dysfunction, both primary and also secondary from the fluid redistribution problem, and alleviating that and getting oxygenated blood flowing through the organism, through the body, it looked promising, at least the article that I read. But that's a whole day's worth of talks just in the one thing. It's such a complicated problem.
I wanted just to throw up one slide about diagnosis and one or two slides about treatment. But those two things, diagnosis, you can spend an hours on that, properly diagnosing septic shock and everything to do with it, and what's going on with the patient at what stage they're at. And then the treatment, I just threw in the quick emergency room. Person walks in, there is a whole ICU a scenario of treatment that has to do with about a dozen different aspects of the clinical picture that we need to pay attention to, way beyond just giving them some fluid. This was I didn't want to, you can't put so many things in a lecture, you'd be here for 5 hours talking about it, right? So I want to just throw up the quick down and dirty of when people walk into the ER, but the treatment goes on for weeks, and it's ICU, and it's a whole world of things to manage there as people go through this. And then when the Sears response maybe does subside and the CARS response now is predominant, it's interesting. And you've seen people who they say have septic shock, but it's multi-pathogen. It's not just one pathogens that they discover they have. Yeah. And this can happen when the Sears response tempers and the CARS response becomes more powerful, and it's a little bit of an immunosuppressive effect because it's trying to temper down the effect of the Sears response, which is an attack on the pathogen. It's tempering that down. Well, if it goes too far the other way, it's almost an immunosuppression. And now you can get a nosocomial infection in the hospital or from something else,
Sure, absolutely. But of course, we didn't even touch on, and again, I understand it's impossible to do that, but you have CRRT. How can that benefit you? You have the cytosorb, which Tammy just got through talking about, and how can that help you in attenuating this massive inflammatory dysregulation that's going on and being able to modulate that? Then you have the stuff that I think Dr. Simpkins had talked about once before with the nitric oxide attenuators and redistribution solutions that he has, that he's working on. There's so many things that are being looked at, and how we manage these patients. But I'm struck by how can we be a part of that. I think the CRRT and the cytosorb are two very important things. And of course, I think if ECMO is something that can be beneficial, then I think that's something we need to be looking at, because we're very comfortable with thinking about VA ECMO for a PE protocol. If you have a PE team, and that's what you're going to do to manage those patients. These patients, too, are suffering from circulatory collapse. And if you don't have, not only do you now have the problem of your nutrients getting to the tissue, you have the circulatory system not even able to deliver the nutrients to where they need to be, poorly being utilized. So it is that cycle that we see frequently occurring. And how can we be a part of solving this dilemma for patients who have, again, predictably very high mortality?
Yeah, I mean, you saw how one of the big first early steps of this whole demise of the endothelium was a large release of the cytokines, right? An enormous release of the cytokines by the white cells, who are panicking to the fact that they may be outnumbered. So they're recruiting as heavily as they possibly can. And they only stop doing that, by the way, when new white blood cells, leukocytes, stop running into more and more pathogens, right? The new white blood cells show up, but if they run into a whole crowd of pathogens, they release that much more cytokines. And so on a localized infection, white blood cells show up, they release the cytokines, but the new white blood cells show up, but they don't run into any more pathogens. The white cells that were there have already surrounded the pathogens, and it's becoming contained. In a systemic-wide system, the white cells that are new white cells on the scene keep running into more and more pathogens. So it's a snowballing, why they call cytokine storm. In the meantime, the endothelium is ill-equipped to handle this level of cytokine circulation in our system. And then if you have that many pathogens, these are purposely releasing toxins. The endothelium is ill-equipped to handle large levels of endotoxins being released by the pathogens.
And then you're killing it, and even then you're killing it, and then endotoxins are getting released, and those are even just as damaging.
Yeah. So, the nitric oxide gets released by the damaged endothelium. That causes a problem of mass vasodilatation and drop in blood pressure. So if we could temper down the nitric oxide quantity that's circulating, that might help. If we could temper down the cytokine storm or the cytokine release, I mean, the damage to the endothelium might be less, but then maybe you're not recruiting the amount of white cells you need to recruit, which was the purpose of it releasing so much cytokine.
And of course, in my go ahead. I'm sorry.
Well, when we looked at the mortality rate early on, which you mentioned right out of the gate, now I hope that people can kind of see why this carries such a high mortality. You know, when you start to strip away one of the most, maybe the most important thing about our homeostasis is the endothelium. When you start to strip that away, all types of, you know, very unfortunate things begin to happen.
Yes.
And I didn't go into it, but there is a whole system in place that the body has to try to lay down. There's cells that get laid down to replace the endothelium. There's a whole system that you could talk about at length. Also, it's not all covered with platelets like I showed. There's an attempt by the body to replace the endothelium cells. They're not with other endothelial cells right off. There was some other type of cell, but the body does have a little bit of an avenue to try to patch up these areas of endothelial that are being released and separating from the vessel wall. But I don't know at what rate that happens and how much reserve we have and how depleted that could be. You know, that's a whole. There's so many topics that you could
sure.
hit.
Well, I believe that, I fundamentally believe that that oxygen starvation to the tissue will lead, of course, to ever increasing amounts of dysfunction, and that if you can keep the total organism alive, keep the circulation going, the antibiotics can get where the antibiotics need to be because you have circulation. All of those things will play a role in being able to really survive sepsis. So I do think there's a role for mechanical circulatory support in those patients for no other reason than to keep the major organ systems functioning, fed, and alive in order to be able to battle whatever the underlying disease is. But once you get into an oxygen deficit, a tissue cellular oxygen debt, that you can't overcome it, because without that you have nothing.
Well, I mean, you make a point of if you can keep the organism alive and by a significant amount of time, and we can then get the upper hand on the infection, and the white blood cells, like I said, the newly recruited white blood cells begin to stop running into and attaching to the pathogens. They no longer release any more cytokines. The pathogens begin to dwindle. They're releasing less and less of their toxins, and we can begin to reverse this process and go back, hopefully, towards, a non-infectious state. How long does it take before the endothelium regains enough of its function? Enough of it can be repaired, replaced, whatever the body's process is there, to where at least the endothelium stops with all of its dysfunction. You'd have to ask somebody smarter than me about how long that might take before you get all of these things back in alignment again.
Yes, very good point. John, we've run over a little. Thank you so much for your generous time. I'm going to go ahead and end it here, but we are going to come back and tackle this very topic. You really struck a chord in me, and I think in our viewers as well, because this is a big problem that is largely not on our radars as perfusionists, but should be. And I think that we need to focus on this again. There's no doubt about it. I wanted to thank everyone for coming and watching today. Tomorrow is going to be our very first attempt at streaming live an ECMO simulator, patient monitor, ventilator, recirculation technology. There's going to be a multitude of technologies, 5 or 6 cameras, all trying to work in harmony with each other. And it's been David and Magic's job to get this done. I think they're ready. They have done an exquisite job. We're going to practice one time today. It could be a dumpster fire. I've got my goat, my screaming goat that I have here just in case it all goes to a dumpster fire.
You're welcome.
We're going to do our very best to make sure that it goes well. I hope you could join us and see it. But with that said, I'm going to bid you all a good evening, and I look forward to seeing you tomorrow morning at 8 o'clock for our first ever live ECMO simulation with 4 simulation scenarios. I'm hoping it goes well. So if it doesn't, it'll be fun to watch. If it does, it'll be informative to watch. So we're looking forward to seeing you tomorrow. John, thank you.
Well, Joe, you're pioneering perfusion education. I got to hand it to you on that one. That sounds like an incredible idea. And you know what? Even if you're not totally successful tomorrow, although I think you're going to be, you'll learn from it, and you will be the next time. So I'm going to tune in just to see what it is all you're talking about. I can't even imagine. I can't even imagine what this is going to look like. But I'm intrigued.
It's going to be interesting. I think you're going to really be impressed. The guys worked for a couple of months putting all of the technology. You don't see it. You can't see it. But we have such different stuff now, John, different streaming software. We have different ways of bringing people into the meeting without having to use Skype or Zoom or one of those other things. It's all of our own internal stuff. You know, David, from a systems perspective and and being able to have these technologies work, and of course Magic, who makes these things talk to each other and do all of that kind of stuff. They've worked for a couple of months, and we have a new ECMO simulator from Eigenflow, which I'm going to be able to show you tomorrow, which I think you're going to find very interesting. It's a great ECMO simulator, does a lot of really neat stuff. We have a new patient monitor and ventilator where we can simulate COVID patients, ECMO patients, pretty much anything that you want to do with these patients. And being able to show all of these things in a way that I'm hopeful is educational, not just one camera moving around, but multiple cameras looking at multiple things all at the same time, so that the viewer can experience what it would be like to be in an ICU room with an ECMO patient. And again, you know, it's our first time. We're going live with it tomorrow. We've trialed it a couple of times. We've had some encouraging outcomes, and we've learned some things from the trials. We're going to do it again tonight before the guys leave. We're going to try it one more time. And you know, I'm not an overly religious guy, but I'm going to say some prayers tonight, and I'd appreciate it if you all would do the same thing, because it could be interesting.
Well, I look forward to it. I hope to check it out.
All right, looking forward to it. John Ingram, thank you very, very much for your expertise. That was an incredibly informative lecture. I learned a lot, and it's really got my mind thinking about how we need to pursue this even farther, because it's an incredibly complex and interesting topic and phenomenon that occurs to patients, and I think there's some things we can do to benefit our patients that come into our hospitals respectively.
Yeah, absolutely. Let's hope so. Let's hope it leads to some progress.
Thanks, man. I'll see everybody tomorrow morning. Be safe.
Thank you, guys.